I'd like to just, since we are on this topic and we are starting with coronary calcium expert, quickly switch to Roger and pose the same questions and see if you have any comments right about these two issues, the radiation and the reproducibility.
Well, one of the issues, of course, that we didn't mention is the incidental findings. And one problem that a lot of people say is that, and I've experienced in patients that I've referred, is typically that 5 to 10% of people, depending on their smoking history, and it's higher as you get older, will have some incidental findings that you need to do a full CT, often with contrast. At Hopkins at 6 months and then another year, and that raises a lot of concerns also. Why don't you go to the next slide and let me just go through a couple of these real quickly and then make a few general points. So this is just an example of limitations of Framingham. The main reason we think about coronary calcium is that Framingham score has limitations. This is just sort of showing, it's Audrey Hepburn up there, that no matter whether it's age 40 or 50, it's still a 10-year Framingham risk score of 8%. That's because as you get older, you get fewer points for smoking and total cholesterol. So one reason to think about imaging is that Framingham doesn't get you that magical 10% risk, and this person has really high risk factors. Next slide. This is just sort of reminding us that Bill Clinton had lots of doctor visits and never had a coronary calcium scan, had extensive disease, and he was always right around that 10% 10-year threshold. So a slide that all of us have used a lot, if he had had a scan maybe back when he was in his 40s, a good chance it would have looked like the one on the right. Next slide. Now, keep in mind, I always ask about less than 45 for men, less than 55 for women. This is just looking at the median scores. One problem is that median scores are awfully low when you have in that 40 to 44 range. The theory is that if you want to start people on therapy earlier, if you have a score, say 50, and that's about the 90th percentile, then you would go ahead and start therapy. But we really don't have the clinical trials that tell us that. Next slide. Now the women makes it even harder if you say less than 55. Here the 90th percentile is about 50 there. So we have these different thresholds, and you're basically, the only reason to consider the scan is to try to decide earlier start of aspirin or lipid-lowering therapy. And this is one of the studies that Matt, Coram, Aaron Nikos, and I had worked on, just looking at the prevalence of a high coronary calcium score greater than 100, which we all would say is associated with a higher risk. You can see even if no other risk factors there, if you have a family history of premature disease in siblings, it's about a quarter of these individuals with no other risk factors had significant coronary calcium. And then finally, with family history of premature disease, if you have that with, say, 2 metabolic syndrome risk factors, about half of those individuals will have a high coronary calcium score greater than 75th percentile. So I don't know if I have anything else after that.
Okay.
So the key issues, I think, are that, one, we don't have the clinical trials. We have to remember that the statin trials of 5 years are looking at older individuals, west of Scotland, AFCAPS, and Jupiter. We think we have enough data to say that we're slowing the progression of atherosclerosis, and that's very important. The only real good studies we can look at are the PAC study and the Dallas Heart study that shows differential, especially with a family history of heart disease, seems to be associated with increased risk. And then the final thing is that you asked about, is IMT a better tool? And I think since so many people less than 45 for men, less than 55 in women are going to have no or minimal coronary calcification, it would make sense to say you could do an IMT, but the problem for practical things, even at Hopkins, we can't order an IMT clinically. And the big limitations, as we'll hear about in a few minutes, are that you really need a good technologist who can do these measurements. And from Jim
So that's why we're here. That's why we're here, Roger. Let's go back to Dan's comments on radiation and reproducibility. How do you comment on that? Do you see that radiation becoming a major increasing issue, or as we go forward, we should expect the radiation will be less and less an issue with the technology development?
We expect it'll be less and less, and probably in that 1 to 1.5 millisievert range is what we'll do for the coronary calcium scores, and maybe it'll get even lower. The issue you have, besides the radiation, is those incidental findings, and that also increases costs and certainly increases anxiety. And it's been a problem with that we've seen it happen, just having a run of these incidental findings that require the full scans.
Yeah, we added incidental finding to the list that you brought up. How about the issue of reproducibility? That is a major issue with regard to IMT. How about reproducibility for coronary calcium?
We know that when you're in that 0 to 10 range, then you're going to have more variation. But basically, what you're looking at is on a cross-sectional basis. Do you have a score that's, say, 50 or higher, that would say you're clearly at an increased risk of progressive atherosclerosis than you treat earlier with statin therapy? Our data on aspirin and primary prevention doesn't look very good right now. But we're mainly talking about statin therapy and better lifestyle habits.
Yeah, we're going to go to the treatment. So the reproducibility is not as an issue here as it is with IMT, but with the range of between 1 to 10 or less than 50, you think reproducibility is still as an issue with CT. And does it depend on CT scanner, type of scanners, and so on?
Well, it does, but you're basically just trying to say, are you clearly above the median, or you're clearly above the 75th percentile if you're thinking of doing that in an individual with a family history of heart disease. So whether your score is 35 or whether it's 50, it really doesn't make that much difference if the median for your age is going to be 0 to 5.
Okay.
Right. So I think we're thinking percentiles in this younger age group.
Mort, I do not think the reproducibility is a problem. It just is the number. If you look at it as high as a percentage of the, but it's not clinically a problem. It's a problem if we're trying to do serial studies that follow progression. That's nothing that is currently being thought
Well,
of.
the issue is for the screening purpose. It might not be a problem at Cedars-Sinai, but if somebody goes to a community clinic, gets coronary calcium, and the result is 10, and comes to your clinic and gets the results of what, 80, 90, 50? Would that be that kind of?
No.
Plus or minus 20%.
The
So 10 to
protocols
12.
and the protocols are standardized. This is a relatively easily performed technique that within these zone of around 20%.
20%. So it would be 10 would be 8 to 12.
Unlike a thallium scan, when someone comes in with an outside thallium scan, I don't know if I'm going to be able to read it. Somebody comes in with an outside coronary calcium score, I basically am going to be usually just trusting that in that person's management. One other thing I wanted to mention I didn't get from my presentation is that we had just published recently on getting down to 1 millisievert instead of 1.7 by changing the protocols. Different approaches are being evaluated, so I think the comment that it is getting better is appropriate.
Yeah, okay.
And there is a progression formula that takes account of any baseline score. You can monitor progression. That is used, that came out of our institution in Colorado, and it's published. And the interscan variation in the EBCT is about 8%.
So we hear from the experts here that it is within the reasonable range.